I think the question is, what is a monoclonal antibody adding toxicity-wise versus benefit? And
So I would like to come back. So I actually asked you, Ajay, before from the NCCN guideline, and you were very savvy here to start bringing up all the data, but the RVD with VODdaraa is actually not yet in the NCCN guideline. It probably will, but it's actually not yet. So if you look in the NCCN guideline, you have the VOD regimen. You could prescribe the RVD with daratumumab, but then you have to have approval for commercial insurance, and you could use it based on the data we're discussing. Yeah. But if we go back to the NCCN guideline today, the recommendation, if you're not going to use RVD, are either CyBorD or KRD. So let's go back and look at the data. So you called us out here and said, when are you going to change? So do you have to wait for the randomized study, or can you look at the data and be smart yourself? So let's do the same exercise here. So the VODdaraa, how much was the MOD rate for that combination from the Griffin study? Was that around 40%?
40 to 50%.
So what was the KOD data that's presented in 2 phase 2 trials? That's 50%. So why do you need an antibody if you have a superior proteasome inhibitor?
So that's a great question. And I think what we don't talk about a lot when we do the PI comparisons is doses, schedules, and number of days of treatment, right? KRD is a 28-day cycle. RVD historically has been a 21-day cycle. So 4 cycles is actually an extra month of chemo. Secondly, the doses matter, right? So we all know that in the Endeavor study, K56 twice weekly was superior to bortezomib 1.3 twice weekly. I don't think anybody questions that. But when we start going down to different doses and schedules, you can give carfilzomib at 20/27, which is the initial approval. You can give it at 70 weekly based on ARROW, and you can give it at 56 twice weekly. I think there is concern now about going to weekly 70 with a concurrent IMiD. So most of us, I don't think, are doing that. And so the question would be...
56 is the recommended dose
So
with an
then
IMiD.
I would say, give me a study that shows that K56 weekly is superior to VRD.
So that has not yet been published, but you just said that we don't need randomized studies. So there are studies showing that 56 with VODdaraa and IMiDs, they are presented at this ASH. There are 2 presentations, and they are way higher than the VOD with VODdaraa in terms of MOD rates.
But I would argue we do have 2 randomized studies. We have VODdaraa VTD and VODdaraa VRD. These are randomized head-to-head studies.
But we don't need randomized studies.
Huh?
We don't need randomized studies.
But no, but my point is, this is actually an era where we have more data than we did with the RVD single-arm study, right? So we actually have more data.
Yeah, so I don't think any of us here is afraid to use VODdaraa RVD. I think we all think it's a safe and potent regimen. The question is, does everybody need it? And I think this discussion of the potency of the first-line therapy ignores what happens next a little bit. Because with RVD, almost all our patients are going to be feeling better and doing better after a month or 2 of therapy. So what you're really shooting for by adding more is a better long-term outcome. And I don't think we know for sure that adding VODdaraa now is better than giving VODdaraa later. And I think that's...
But we know VODdaraa VTD already led to a PFS improvement. It wasn't just depth of response.
But what is the clinical significance of a PFS improvement when the patient progresses? It's not
I think that's spectacular in 2019 to get a PFS improvement at 18 months when the median overall survival of myeloma can be as long as 10 plus years.
Like I said, it is a potent regimen, and I think if we see an overall survival benefit, we should use it for everybody.
So I would argue, okay, so I'll challenge you and say, give me a study where PFS2 was compromised, because you're saying my concern about using a more effective regimen is that the subsequent line of therapy will be diminished. Has there been a VODdaraa study where PFS2 has been compromised?
Show me a study where the control arm was allowed to get VODdaraa at progression, and that was how you might answer that question.
But the overall survival is fraught with this question, right? But let's stick to the question at hand, which is, if you get VODdaraa up front, does that lead to a worse relapse?
But we don't know that yet. The data's just not mature enough yet.
Well, Pollux and Castor have both shown that PFS2 is not compromised.
That's true for Pollux and Castor, but what's going to happen is we're going to have these patients come in from Griffin, and we don't know what's going to happen.
But this was the same argument with RVD. Oh my God, we're going to use all 3 of our drugs up front. What's going to happen to these patients later?
The question is, can you generalize the same?
But I think that it goes back to, are you an early adopter or not? I will say I've made my...
So are you going to do VODdaraa KRD transplant, VODdaraa KRD consolidation? Is that what you'll do?
I think the KRD question, which Ola was raising, is an important one, and I welcome your thoughts. But I personally think if you're going to use a quad, I'm not convinced that the K56 once weekly is going to be superior to bortezomib when you also have when you also have the DARA and the LEN there.
Well, I think ASH 2019 will clarify that. And I know 2 presentations, and I'm giving one of them. I'm not going to tell you yet because the data is not out there, but the data I think is very strong. So let's go and look at ASH, and we have this meeting again in early 2020.